In the year 1842, Paris was a city of intellectual fervor and scientific curiosity, but it was also a city of contradiction. The dawning age of enlightenment and reason collided with the brutal realities of mental illness, which at that time was poorly understood and even more poorly treated. It was in this atmosphere that one of the most perplexing and chilling cases in psychiatric history would unfold, a case that would haunt the medical community for years to come. Imagine, if you will, a man who speaks only in medical diagnoses. A man whose every word, every sentence, seems as if it were lifted straight from the pages of a medical textbook. He speaks not in the language of a patient, nor in the language of a man, but in the cold, detached terminology of the scientific world, a world that, at the time, still viewed the human mind as a mystery too vast and too complex to ever truly understand. This man, whose name has been obscured by time, was admitted to one of Paris' most notorious asylums. The strange nature of his condition sent ripples through the medical establishment, as doctors and scholars alike tried to make sense of his bizarre behavior. His case defied all conventional understanding, offering no clear answers and presenting more questions than anyone could hope to answer. What could explain a man who no longer spoke as a human being, but as a walking medical report? Was he a living enigma, or was there a scientific explanation that had yet to be uncovered? At the heart of this story is the undeniable mystery of his condition, a mystery that cuts to the very core of psychiatry's early days. In 1842, psychiatry was still in its infancy, struggling to separate itself from the darker and more primitive practices of the past. Patients were often treated with methods that now seem almost barbaric: restraints, isolation, electroshock therapy, and yet, there was an emerging desire to understand and, perhaps, cure the diseases of the mind. But the tools available were limited, and the understanding of the human brain was still in its early stages. In a world where mental illness was often equated with madness or moral failure, this patient's condition seemed to transcend such simplistic labels. His bizarre speech patterns were not merely signs of madness but seemed to reflect something deeper, a strange disconnection between the mind and the body. This was no ordinary case of psychosis or delirium. This man spoke only in medical diagnoses, yet his mind seemed both intelligent and entirely removed from the reality most of us experience. Why was he speaking in this strange, clinical language? Was it a psychological defense mechanism, an attempt to distance himself from the emotional pain of his reality? Or was it a symptom of some deeper neurological disorder, one that blurred the line between cognition and expression? Perhaps it was a combination of both. For the doctors who treated him, every answer only led to more questions, as they tried to understand whether his condition was a rare psychological disorder, a medical anomaly, or something altogether more mysterious. As the story unfolds, it becomes clear that this case would not be a simple one to solve. It would test the very limits of contemporary medical knowledge. And yet, despite the exhaustive efforts of the medical professionals who tried to diagnose him, the patient remained a riddle, one that they could not crack. The very fact that he spoke in terms most doctors would only use in the cold, sterile rooms of their clinics or their books suggests a deeper connection to the science of the human mind, a connection that was never fully understood in his lifetime. And yet, his case would go on to influence the way psychiatry would evolve, forcing the medical community to confront its own limitations and biases in the pursuit of understanding the human mind. His story takes us to the heart of 19th century Paris, a city caught between the allure of scientific progress and the harshness of its treatment of the mentally ill. At this time, asylums were not places of healing, but rather places of confinement, where the mentally ill were often treated as little more than prisoners of their own minds. The methods used were crude, with doctors relying on the limited knowledge of the time to try and cure patients. While some doctors, like Philippe Pinel, began to call for more humane treatment, many were still entrenched in the idea that mental illness was a moral failing or a physical affliction that could be fixed through the application of physical force or restraint. This patient, with his strange speech and incomprehensible behavior, was not the kind of case that could be easily dismissed or explained away. He was a living contradiction in a world where mental illness was still misunderstood. Doctors at the time were accustomed to seeing patients who were withdrawn, violent, or delusional, but they had never encountered a case like this, a man whose speech was not just incoherent or nonsensical, but entirely clinical. It wasn't just that he spoke in terms of diagnosis, he did so with a precision and accuracy that was both alarming and fascinating. He would describe his symptoms and condition with the same detached tone a doctor might use to explain a diagnosis to a patient. He would refer to his own psychological state as though it were a subject to be analyzed, with no emotional attachment to his words. His speech lacked the human qualities we take for granted, emotion, empathy, even self-awareness. Instead, it was cold and clinical, as if he had ceased to be a man and had become a mere vessel for medical terminology. As the weeks turned into months, the medical staff became increasingly obsessed with the case. They began to document his every word, his every utterance, hoping that by understanding his speech, they might unlock the mystery of his condition. But each new observation only added to the confusion. Was this man simply suffering from some rare form of mental illness, or was he a victim of a deeper, more complex neurological disorder? The more they tried to understand him, the more they found themselves facing an impenetrable wall. They began to question the very foundations of psychiatric theory. Could it be that the mind itself was even more mysterious and incomprehensible than they had ever imagined? Was this patient, with his medical diagnoses and strange detachment, a glimpse into the future of psychiatric science, or was he a tragic symbol of the limitations of 19th century medicine? What is most unsettling about this case is the eerie sense of inevitability that surrounds it. Despite all the progress of the 19th century, despite the efforts of the best medical minds of the time, this man's condition remained a mystery, a riddle that could not be solved. He was trapped in a cycle of diagnosis, unable to break free from the cold, unfeeling language of the medical world. And perhaps, in a way, he was a mirror for the very state of psychiatry itself, a field that, despite its noble aspirations, was still groping in the dark, trying to understand a mystery that it was not yet equipped to solve. This mystery would live on in the annals of psychiatric history, an unsolved puzzle that would continue to fascinate and baffle those who sought to understand the human mind. It would also serve as a reminder of how far we have come in the field of psychiatry, and how much further we still have to go. In the case of this patient, there were no easy answers, no tidy conclusions, only more questions. And as we explore the strange, tragic, and ultimately unresolved story of this man, we are forced to confront the uncomfortable reality that some mysteries may never be fully explained, no matter how much time passes or how much we learn. Paris in 1842 was a city teetering between the old world and the new, a metropolis where the spirit of the Enlightenment had sparked intellectual revolutions, yet much of the populace remained trapped in the shadows of superstition and ignorance. The streets were lined with grand boulevards, but also with the poor and the destitute, while scientific discovery was flourishing in universities and salons, far removed from the daily struggles of those living in the slums. This was a city on the cusp of modernity, but still deeply haunted by the beliefs of a more primitive age. The treatment of mental illness was one of the areas where the clash between old and new was most apparent, and the state of psychiatric care was both a reflection of society's fear of the unknown and a testament to its slow march toward understanding. In the first half of the 19th century, psychiatry was still a deeply nascent field, struggling to emerge from the shadows of its barbaric past. People with mental illnesses were often seen as little more than cursed or criminal individuals, their suffering viewed through a lens of superstition and religious judgment. They were frequently locked away in asylums, treated not as patients but as prisoners of their own minds, confined behind high walls and cold iron gates. There, they were subjected to primitive methods of treatment that would shock modern sensibilities: bleeding, purging, or even cruel confinement to cells so small they were hardly more than cages. The belief was that insanity was a moral failing or the result of divine punishment, and as such, the treatment often involved measures that were as brutal as they were ineffective. But amid this grim reality, a slow and uncertain revolution was unfolding. The first stirrings of modern psychiatric thought were beginning to emerge, and thinkers like Philippe Pinel and Jean-Martin Charcot were starting to challenge the conventional wisdom of the time. Pinel is often credited with being one of the first to advocate for more humane treatment of the mentally ill, insisting that the mentally ill should not be treated as criminals or animals but as human beings deserving of dignity and care. His efforts to unshackle the patients at the Bicester Asylum in Paris marked the beginning of a shift toward recognizing mental illness as a medical condition, rather than a moral or supernatural one. Still, this was a time of great uncertainty in the medical field. The theories surrounding mental illness were in flux, and psychiatry had not yet found its footing. Doctors and researchers were grasping at straws, trying to understand the mind and its afflictions, but they had no clear answers. While the prevailing medical community began to acknowledge that there was a physiological basis for mental illness, they had little understanding of how the brain worked, how it could malfunction, or how to treat its disorders. The brain was still largely a mystery, and as a result, mental illness was often treated as an abstract concept, a puzzle that couldn't be fully understood by the methods at hand. In this context, the case of the patient who spoke only in medical diagnoses emerged as a particularly unsettling mystery. The very nature of his condition, The fact that he could only communicate in the cold, clinical language of diagnosis was a reflection of the very disjunction between the emerging medical understanding of the mind and the brutal realities of psychiatric care at the time. Here was a patient whose mind seemed to be both beyond comprehension and yet perfectly aligned with the medical knowledge that was beginning to take root in Paris. He was not speaking as a man or a human being, but as an abstraction, someone trapped between the realms of humanity and the cold, detached world of science. In 1842, the field of psychiatry was still heavily influenced by the prevailing scientific and philosophical debates of the time. Theories of mental illness were deeply entwined with larger questions about the nature of the mind and the soul. Some doctors believed that mental illness was the result of physical damage to the brain or nervous system, while others saw it as a moral or spiritual failing. There were those who looked to the soul for answers, suggesting that madness was a punishment for sin or a sign of divine wrath. Meanwhile, others were turning to emerging scientific fields, such as phrenology, the belief that the shape and size of the skull could reveal information about a person's mental state, as a way to understand the mind. The fascination with the brain and its potential to explain human behavior was growing, but it was still in its infancy, and much of the understanding was based on speculation rather than evidence. In this environment of scientific uncertainty, it is not surprising that the patient's condition would provoke such confusion and fascination. His ability to speak only in medical diagnoses seemed to defy every theory that was being proposed at the time. He was not simply a man who had lost his ability to speak normally. He was a man whose mind seemed to be functioning on an entirely different plane, one that was purely intellectual, devoid of the emotional or humanizing qualities that we typically associate with speech. His language was technical and precise, yet it lacked any of the warmth or depth that we would expect from a person trying to communicate their feelings or their experiences. It was as though he had become a vessel for medical terminology, unable to break free from the rigid framework of clinical diagnosis. This disconnection between mind and speech was both fascinating and terrifying to the doctors who encountered him. In an era when medicine was still largely a trial and error endeavor, the patient's condition represented an enigma that could not be easily solved. His case seemed to reflect the very limits of the medical knowledge of the time. Was this patient the product of a physical injury to the brain, or was he suffering from a psychological disorder that defied understanding? Could his behavior be attributed to a spiritual malady, or was he simply a victim of a disease that had yet to be named? There were no easy answers, and each theory seemed to lead to more questions. At the same time, the medical community in Paris was undergoing a shift in how mental illness was perceived. The idea that the mind could be treated with reason and science was slowly gaining ground, but it was still a controversial and radical idea. The concept of the asylum was evolving, albeit slowly, from a place of punishment to a place of care. Doctors were beginning to look for scientific explanations for mental illness, though they lacked the tools to truly understand the complexities of the human mind. This was a time when the early steps toward modern psychiatry were being taken, but those steps were hesitant and fraught with uncertainty. As this new age of psychiatric inquiry began to take shape, the patient who spoke only in medical diagnoses became a symbol of that uncertainty. His condition could not be neatly categorized or explained by the emerging theories of the time. He was a living paradox, a figure who existed at the intersection of the old world and the new, embodying both the fear and fascination that mental illness inspired in the public and in the medical community. In his speech, which was neither entirely coherent nor completely detached, there seemed to be a suggestion that the mind could no longer be understood simply in terms of morality or divine will. Instead, it was a complex, multifaceted entity, one that could only be grasped through the lens of emerging medical knowledge, but also one that could not yet be fully explained or treated with the tools at hand. The juxtaposition of this patient's strange behavior with the evolving medical theories of the time encapsulated the tension between tradition and progress that defined much of 19th century Paris. The city itself was caught between the promise of modernity and the weight of its past, and the treatment of mental illness was no exception. It was a time of both hope and despair, as scientists and doctors began to push the boundaries of what was known, while still clinging to the outdated methods that had long defined psychiatric care. In the case of this patient, the search for answers would go on for years, and his story would become an enduring reminder of the challenges that lie in trying to understand the complex nature of the human mind. The man who arrived at the asylum in 1842 had already become the subject of much speculation before he even set foot inside its grim walls. His case had baffled family, friends, and physicians alike, each person who came into contact with him finding themselves drawn into the strange enigma of his condition. He had once been a man like any other, a person with hopes, fears, desires, and ambitions, but something had shifted within him. His ability to communicate in any normal sense had been replaced by an odd, clinical language, one that made little sense to anyone who tried to interact with him. Instead of speaking as a man, he spoke as though he were a walking medical textbook, his every word and sentence framed in the language of diagnosis and pathology. The moment he entered the asylum, the staff were both intrigued and deeply unsettled. Asylums at the time were not places of healing in the modern sense. They were often dark, oppressive, and dehumanizing institutions, where patients were more likely to be locked away in silence than to receive any form of compassionate care. And yet, within these walls, doctors and attendants were still trying to make sense of the human mind. The man's arrival presented both an opportunity and a challenge. For the medical staff, he was a puzzle, an opportunity to test their theories and an invitation to solve a mystery that had stumped their colleagues in other parts of Paris. But as with many such mysteries, the answers did not come easily. He was introduced to the staff, and it soon became clear that this man was unlike any other patient they had seen. He did not speak in the way that others in the asylum did. Most patients in such institutions, whether due to trauma or mental illness, spoke incoherently, shouting or babbling, expressing their pain or confusion in ways that were disjointed and erratic. But this man's speech was different. It was precise, clinical, and deeply disturbing in its detachment. He would describe his symptoms with exacting detail, using terms that were common in medical texts of the time. Paralysis of the left side, he might say, or auditory hallucinations of a tactile nature, as if he were reciting a diagnosis from a textbook. It was as though he had somehow detached himself from the human experience, turning his condition into a set of cold, scientific observations. The staff, first fascinated by the unusual nature of his speech, began to treat him like an intellectual curiosity. There was no sign of madness in the way he spoke. His words were organized, coherent, and sharp. He was not speaking as a delirious patient, nor was he lost in the confusion of a psychotic episode. Yet he was clearly not like anyone they had encountered before. His speech was completely devoid of personal emotion or subjective experience. There were no cries for help, no expressions of pain or fear. He spoke of himself as though he were describing the condition of a distant stranger, someone entirely separate from the man whose body he inhabited. As the days passed, the staff attempted to engage him in conversation, hoping to uncover the nature of his affliction. They asked him about his life before his condition had overtaken him. But each time, the man would respond in terms of his medical diagnosis, describing his symptoms and physical state in minute detail, but offering no personal insight or recollection. When asked about his family, his response was technical. Subject reports no family history of hereditary mental disorders, though mother suffered from a generalized anxiety disorder of undetermined origin. When asked about his childhood, he responded similarly. Patient does not recall any traumatic events, but exhibits signs of an anxiety-based disorder, likely exacerbated by social isolation. It became clear that the man could no longer access the normal framework of memory or emotional connection. His recollections were not of past experiences, but of medical symptoms, a catalogue of maladies and diagnoses, as though he were mentally incapable of framing his life in any context other than clinical terms. His past, which he had once lived as a human being, had been reduced to a set of symptoms, and he could only reference himself in terms of the afflictions that had overtaken him. It was as though his entire sense of self had been overwritten by the medical language he now spoke. The staff, for all their training and their interest in mental health, were left scratching their heads. Was this a case of profound dissociation? Had some trauma or psychological break caused this man to retreat into the language of science, stripping him of his human experience? Or was his condition the result of something more physiological, a neurological disorder that had somehow rendered him unable to access normal forms of speech? His case was both a medical marvel and a psychological puzzle, and it quickly drew the attention of some of the most prominent doctors in Paris. One of the first to examine the patient was Dr. Jean-Martin Charcot, a prominent neurologist and one of the leading figures in the study of hysteria and neurological disorders. Charcot, who had gained fame for his work on hypnosis and his study of the nervous system, was intrigued by the man's condition. Charcot was one of the pioneers of the idea that mental illness had a physiological basis, and he believed that the brain could be studied in much the same way as other parts of the body. He was fascinated by the patient's ability to describe his condition with such clinical precision, and yet Charcot was unable to determine the underlying cause of the man's behavior. His speech, although entirely clinical, was too systematic, too rigid, to be explained away by the more common diagnoses of hysteria or dissociation that Charcot had seen in other patients. What was perhaps most disconcerting was the man's lack of emotional engagement with his condition. Charcot had encountered many patients who, although suffering from the same symptoms, were still able to express fear, confusion, or even anger about their condition. But this patient showed no sign of these emotions. His responses were delivered with the same cold detachment, whether he was speaking about his paralysis, his hallucinations, or his inability to experience normal emotions. The staff at the asylum were left wondering if he even understood the gravity of his situation, or if he had somehow detached himself from the reality of his own suffering. As more doctors visited the asylum to observe the patient, the case became a subject of intense academic interest. The man's unusual behavior offered new avenues for investigation, but it also raised profound questions about the nature of mental illness and the mind itself. Could it be that this man was suffering from a psychological condition so rare and complex that it defied traditional understanding? Or was his condition the result of some unknown neurological disorder, one that had yet to be identified by contemporary science? The mystery only deepened as the man's case continued to resist explanation. The patient, for his part, remained an enigma. He did not seem to have any awareness of the fascination he was provoking, nor did he appear to care about the doctors and staff who were observing him. In fact, it was as if he had become a ghost in his own life, unable to reconnect with his former self, unable to feel any emotional attachment to the world around him. His language, though articulate and precise, was not his own. It had become a shell, a form of expression that had replaced the man himself. There was no humanity in his words, only the cold, detached language of medicine and diagnosis. As time passed, the doctors began to theorize that the man's condition could represent an extreme form of psychological breakdown, a state in which his mind had retreated entirely into the realm of clinical language as a form of protection or defense. But despite their efforts, no clear explanation emerged, and the man continued to speak in the same mechanical, diagnostic terms, as though he were trapped in a world where human experience had been replaced by medical observation. In this strange, clinical language, the man's identity had been subsumed. He was no longer a man with a past, a family, or a future. He was simply a patient, a case study, a walking diagnosis. The enigma of his condition persisted, and it became clear that the case of the patient who spoke only in medical diagnoses would not be easily solved. His story would remain a strange chapter in the history of psychiatry, a haunting reminder of the limits of medical knowledge at the time, and the unsettling complexities of the human mind. In the early days of the patient's stay at the asylum, the medical staff were quick to begin their attempts to understand the cause of his bizarre behavior. They had no choice but to confront the undeniable fact that this man, though coherent in his speech, was somehow unable to communicate in any meaningful way with his doctors or fellow patients. His language, while precise, was entirely foreign to the human experience that those around him shared. In the beginning, they approached him as they would any other patient, asking simple questions, attempting to engage him in ordinary conversation, and hoping that somehow, some thread of the person he had once been would emerge. But as the days turned into weeks, it became clear that this would not be a typical case. His responses were disturbingly mechanical, as if each word had been extracted from a medical text or a diagnostic manual. The staff began to experiment, posing a variety of questions in an attempt to trigger a reaction. They asked about his childhood, his family, his life before the asylum. But every response was clinical, stripped of personal details. He might say, patient reports no known family history of mental disorders, but does exhibit signs of anxiety related to early childhood experiences, or no recollection of familial bonds, but possible attachment disorders observed. His answers never ventured into personal territory. They never hinted at feelings of loss, fear, or nostalgia. It was as though his identity had been entirely replaced by his symptoms. There was no room for a man who had once lived a life, only the cold observation of a medical case. The staff initially thought that perhaps this disconnection was due to a form of dissociation, a psychological defense mechanism in which the mind attempts to shield itself from emotional trauma by severing its ties to personal experience. However, as they dug deeper into his history, it became increasingly apparent that his condition was far more complex than a simple emotional withdrawal. His life before the asylum was unremarkable. He had not experienced any significant traumatic event that could explain the onset of his strange behavior. No accidents, no losses, no emotional crises that would have triggered such a radical shift in his mind. It was as if one day, without warning, He had simply stopped being a man in any traditional sense and become a walking catalogue of medical diagnoses. Desperate for answers, the doctors turned to neurological explanations. Could this be a rare form of brain injury or a disorder affecting the area of the brain responsible for speech and memory? At the time, medical science had only the most rudimentary understanding of how the brain functioned, and even basic concepts of neuroanatomy were still in their infancy. However, the patient's ability to speak with such clinical precision suggested something deeper, perhaps a disorder that was affecting his ability to engage with the world in a human way, yet leaving his intellectual faculties intact. One of the leading theories among the medical staff was that the patient was suffering from a form of aphasia, a condition in which an individual loses the ability to understand or produce language in a normal way. Aphasia was not a well-understood condition at the time, but its effects were becoming more widely recognized as the field of neurology developed. Some believed that the patient's condition might be a form of what was called semantic aphasia, a disorder where an individual loses the ability to process the meaning of words, while still retaining the ability to speak fluently. This theory would explain why the patient could speak in such clinical terms. His brain might still be processing language at a basic level, but the meanings of the words themselves had become disconnected from the experience of living. Others on the medical staff speculated that the patient was exhibiting signs of what would later be known as a form of conversion disorder, a condition in which psychological stress is converted into physical symptoms. Perhaps the patient's mind had created a defense mechanism so severe that it manifested itself as this strange, detached language. Some believed that his mind had retreated into this clinical language as a way to shield itself from the emotional and psychological pain of his condition. In a time when psychiatric diagnoses were often vague and based on little more than speculation, this theory was as plausible as any other. But as the staff continued to observe the patient, they began to realize that none of the prevailing theories could fully explain his condition. His speech was not the result of a psychological defense mechanism, nor was it a symptom of brain injury or neurological disorder. The longer they watched him, the more it seemed as though his condition defied categorization entirely. His ability to speak in such technical terms was not a mere coincidence. It was as though he had adopted the language of medicine as a way of describing his own existence. It was as though his mind had become a vessel for medical terminology, reducing the complexity of human life to a series of symptoms and diagnoses. The more the doctors probed, the more they realized that the patient had no awareness of the full extent of his condition. He was completely detached from the reality of his life. He did not seem to recognize the strangeness of his situation, nor did he appear to be bothered by it. His answers were given with the same mechanical precision whether he was discussing the state of his mind or the weather. He showed no signs of self-awareness, nor did he display any concern for his isolation or his circumstances. This emotional detachment only deepened the mystery. Was this a man who had so completely disassociated from his own life that he could no longer recognize himself as a human being, or was he merely a victim of an advanced neurological condition that had robbed him of any personal connection to his own identity? The doctors, feeling more and more helpless, turned to psychological theories, but none seemed to fit. There was no indication that the patient had any history of delusion or hallucination, nor did he exhibit any of the typical signs of psychosis. He was not out of touch with reality. He simply seemed to be out of touch with himself. He no longer spoke of his feelings, his experiences, or his relationships with others. He spoke only of the state of his own mind, analyzing himself with the same dispassionate accuracy one might use to describe a broken machine. As the weeks went by, the doctors began to wonder if the patient's strange behavior was the result of some extreme form of dissociation, a mental state so profound that it had severed his connection to everything that made him human. Yet, as they observed him more closely, they began to suspect that this condition was not a result of trauma or emotional pain at all, but something far more mysterious. His case seemed to point to a deeper problem, perhaps a malfunction in the very way his brain processed human experience. For the doctors, each attempt to diagnose him only led them further down a rabbit hole of confusion and speculation. Was this man the product of a neurological disorder that had not yet been identified? Was he suffering from a psychological condition so rare and complex that it defied the current understanding of the time? Or was his condition something else entirely, an anomaly that could not be explained within the confines of 19th century medicine? Despite the intense scrutiny and ongoing experimentation, the man's condition remained largely unexplained. Each new theory seemed to fail, as the patient's behavior resisted classification and understanding. The medical staff, once hopeful that they could provide an answer, were left with more questions than before. The patient remained a riddle, his mind and his condition a mystery that no one seemed able to solve. But what was perhaps most unsettling about the entire case was the sense of detachment that seemed to pervade the patient's existence. His inability to speak in any personal or emotional terms suggested a complete disconnection from the very essence of what it meant to be human. And yet, despite his lack of personal engagement, he remained undeniably intelligent, his speech precise, his thoughts organized. He was not a broken man in the traditional sense. He was a man whose very existence had been redefined by the language of medicine. In the end, the patient's strange condition would remain unsolved for many years, becoming a subject of intrigue and fascination for those in the medical community. Theories would continue to emerge, but none would fully explain his condition. His case would stand as a haunting reminder of the limitations of 19th-century psychiatry and the unsettling complexities of the human mind. As the patient's time in the asylum stretched on, the medical staff found themselves at an impasse. Theories had been proposed, hypotheses tested, but none could explain the strange disassociation between the man's intellect and his personal identity. His case had grown from an isolated curiosity into a central enigma, one that consumed the attention of the asylum staff and even drew interest from medical professionals beyond the confines of Paris. However, despite the continued scrutiny and constant effort to understand the cause of his condition, the patient's behavior remained unchanged. He spoke only in medical diagnoses, detached from his own identity, and seemed to exist in a state of perpetual clinical observation, an intellectual ghost rather than a fully realized human being. One of the more troubling aspects of his condition was the way he seemed to have no awareness of his own emotional or psychological state. There were no outbursts of frustration, no expressions of distress, no questions about why he had ended up in the asylum. While other patients in the institution exhibited intense emotional reactions, fear, anger, sorrow, the man showed no emotional response at all. This emotional flatness was not due to a lack of cognitive function. On the contrary, he demonstrated a sharp, analytical mind, able to process medical terminology with precision. Yet, he had ceased to engage with the world emotionally. His detachment was complete. It was this absence of emotional connection that left the doctors so unsettled. In the early days of psychiatry, emotional responses were seen as critical to the understanding of mental illness. The human experience of love, fear, pain, and joy was viewed as an essential part of what it meant to be a person. And yet, in the patient before them, these fundamental human qualities were utterly absent. Instead of a mind grappling with the complexities of human experience, they saw a mind that had distanced itself entirely from those complexities. His condition raised the unnerving possibility that the mind could become so detached from the self that it could no longer perceive or express the very emotions that defined the human experience. Despite his intellectual clarity, his responses remained chilling in their coldness. When asked questions about his condition, he would recite medical diagnoses with a precision that was almost uncanny, but when asked about his own emotions, there was nothing, no reaction, no answer. Even when presented with a situation that would naturally provoke some form of emotional response, the patient remained as detached as ever. The staff began to experiment, introducing elements into his environment that might stir some form of human reaction. They showed him images designed to provoke emotional reactions, portraits of loved ones, depictions of violence or loss, but he remained unmoved, speaking only in terms of his clinical state, as if the images had no bearing on his experience at all. This emotional dissociation was not a symptom of psychosis, nor was it the result of a brain injury or a neurological disorder that could be easily explained. The patient's cognitive faculties were intact. He was not delusional, nor was he out of touch with reality. In fact, his understanding of the world around him was keen and analytical, but his ability to experience the world emotionally had disappeared. His mind, once capable of processing emotions, had somehow become closed off to them. This left the medical staff to grapple with the unsettling possibility that the man had retreated so deeply into the realm of medical science and observation that he had severed his connection to the very emotional and psychological aspects of his own humanity. It was this duality, his intellectual sharpness paired with his emotional emptiness, that made his case so difficult to resolve. On one hand, he was able to process information at a level that would be considered highly advanced, able to discuss complex medical terminology with ease. On the other hand, his complete lack of emotional engagement made it impossible for the doctors to classify his condition using the language and diagnostic frameworks of the time. The emerging science of psychiatry had no category for a case like his. There was no precedent, no model, no clear understanding of what had happened to him or why he had become trapped in this strange, diagnostic language. The more the doctors studied him, the more they began to theorize that the patient's condition was the result of some extreme form of psychological defense mechanism, an effort on the part of his mind to protect itself from something too painful to confront. Perhaps, in an unconscious effort to shield himself from the emotional burden of his life, his mind had retreated into the cold, clinical language of medicine, reducing his entire existence to a series of symptoms and diagnoses. Yet this theory, while compelling, failed to explain the complete detachment the patient exhibited. A defense mechanism would typically be accompanied by some level of internal conflict, some expression of emotional pain or a desire to reconnect with the world. But the patient showed no such conflict. He did not appear to be struggling with the emotional weight of his condition. He simply did not seem to care. This complete emotional detachment was also puzzling in the context of his past. The man had not suffered from any trauma that could be identified as the cause of his psychological collapse. There were no known events in his life that might explain why he had adopted this strange form of speech and behavior. His family history, when investigated, revealed no signs of mental illness or psychological disorder. He had led an unremarkable life, with no history of major emotional upheavals or trauma that could account for his current state. His condition seemed to emerge without warning, as if a switch had been flipped in his mind, and he had suddenly ceased to be a person in the traditional sense. The doctors' growing frustration was compounded by their increasing awareness of the limitations of their own knowledge. They had theories, of course, ideas about neurological disorders, psychological defense mechanisms, and dissociative states. But none of these explanations seemed to capture the true nature of the man's affliction. The more they observed him, the more they were forced to admit that his case did not fit neatly into any existing category. It was not an example of psychosis, nor was it a case of simple mental illness. It was something far more unusual, a medical riddle that refused to be solved. As the months passed, the patient's condition did not improve. He remained a passive observer of his own life, speaking only in the detached, clinical language that had come to define him. The staff grew increasingly fascinated by him, but also increasingly disturbed. The patient, once a man of flesh and blood, had become little more than a clinical object, a case to be studied, analyzed, and observed. He had lost his humanity, not in the way that other patients had, through violence or psychosis, but through a complete and utter detachment from himself. His identity had been replaced by the language of diagnosis, and the result was a man who seemed more like a machine than a human being. But there was something haunting about the way he existed, something tragic in the way that his life had been reduced to a string of medical terms and diagnoses. His condition raised troubling questions about the nature of identity, about the ways in which the human mind can break down and reconstruct itself in response to trauma or emotional distress. What was it that had caused him to retreat so completely into this clinical language? Was it a psychological defense, a last-ditch effort to avoid the pain of living? Or was it something else, a deeper, more inexplicable disorder that could not be understood with the tools of the time? The patient's case would eventually come to be regarded as one of the great mysteries of early psychiatric history. Doctors would continue to study his condition, but they would never fully understand it. His story would linger in the annals of medicine, a haunting reminder of the limits of knowledge and the strange, unfathomable depths of the human mind. As the patient remained in the asylum, doctors continued their observations, but as time wore on, the growing sense of helplessness among the medical staff became almost palpable. Every attempt to engage with him, to draw out any hint of a personal connection, was met with the same clinical, emotionless responses. No one could seem to break through the wall of detachment that had become his entire existence. He no longer seemed like a man trapped in his own mind. He seemed to have transcended human experience itself, becoming nothing more than a series of symptoms, a walking catalogue of medical diagnoses that no one could fully understand. In the early days of his confinement, his condition had intrigued the doctors, many of whom saw it as a rare opportunity to explore the deepest recesses of the human mind. They were fascinated by his ability to recite complex medical terms with such precision. But that fascination soon gave way to frustration as the true extent of his condition became clear. No one could explain why this man, once fully human, had seemingly retreated so completely into a mechanical, impersonal mode of communication. He no longer exhibited any signs of his previous self. His identity had dissolved into his diagnosis, and the person who had once been a man with emotions, desires, and experiences had vanished, leaving only a clinical shell behind. What was most disturbing, perhaps, was that he did not seem to be aware of his own transformation. When the staff first began their observations, They held out hope that there was still some trace of the person he had once been, some fragment of his former self buried deep within his mind. But as the months passed, it became increasingly clear that he had no sense of his past. When asked about his previous life, his answers were disturbingly indifferent. His responses to questions about his family, his past relationships, or even his own childhood were clinical at best, often peppered with references to his condition or the symptoms he was experiencing. There was no longing, no recognition, not even the faintest hint of emotional attachment. He was a man who had forgotten what it meant to be human. This amnesia of self, or perhaps more accurately, this transformation into a clinical object, was one of the most unsettling aspects of the case. The patient did not exhibit the usual signs of someone suffering from a dissociative disorder. He was not living in a state of delusion, nor was he locked in a state of confusion or paranoia. On the contrary, his mind appeared to be functioning at a level of intellectual clarity and precision that would have been the envy of most professionals. And yet, this clarity was void of any real connection to the world around him. He had become, in a way, an observer of his own life, watching it unfold from a distance but never truly participating in it. His mind had fragmented in such a way that he could only interact with the world through the lens of medical terminology, reducing his entire existence to a list of symptoms and diagnoses. For the doctors, this posed a deeply philosophical dilemma. If the mind could detach itself from personal experience to such an extreme degree, what did that say about the nature of identity itself? Was the patient's condition a result of some deep psychological trauma that had caused his mind to retreat into a clinical state, or was this detachment the result of something more profound, a failure of the brain to process human experience in the way it was meant to? Was he, in some way, still the same person who had walked into the asylum all those months ago, or had he become something else entirely? The question of identity haunted the medical staff, and it became clear that no one had an answer. Despite their best efforts, the patient's case refused to fit into any established framework of mental illness or psychological disorder. He was not a typical case of schizophrenia or delusional thinking. He was not suffering from a brain injury that had impaired his ability to connect emotionally. He had simply ceased to be a man in the traditional sense. He had become a walking repository of medical information, unable to access any of the emotional or psychological elements that once constituted his identity. As the weeks turned into months, the doctors began to turn inward, reflecting on their own limitations. In a time when psychiatry was still in its infancy, they had no clear model for understanding this type of condition. The idea that mental illness could be divorced from emotion or human experience was not something they were prepared to deal with. The prevailing understanding of the time was that mental illness was closely linked to emotional distress, a view that had evolved over centuries of medical practice. But in this patient's case, emotion seemed to have been entirely eradicated, leaving only the cold, clinical language of disease and diagnosis in its wake. For many, the case began to feel like a tragedy, an individual who had not only lost his ability to feel but had also lost the very capacity to understand himself as a person. There were no cries for help, no longings for release, no fears about the future. The patient simply existed, locked in a state of perpetual clinical observation, disconnected from the very essence of what made him human. It was as if he had become a living, breathing paradox, a man who was still capable of thought, still capable of language, but completely incapable of living a life in any traditional sense. And yet, there was something profoundly unsettling about the way the patient continued to interact with his environment. His intellectual faculties were sharp. He demonstrated a clear understanding of his medical condition, often speaking with great accuracy about his symptoms and offering insights into the progression of his illness. But his understanding was entirely intellectual. There was no emotional depth, no recognition of the weight of his condition. It was as if his mind had become an abstract entity, an entity that could diagnose itself, but not experience the world through the lens of human emotion. This paradox was mirrored in the way the medical staff responded to him. Initially, many were drawn to him with curiosity, eager to explore the strange nature of his condition. They saw him as a fascinating subject of study, a case that could reveal new truths about the workings of the mind. But as time went on, the fascination began to fade, replaced by a deep sense of unease. The patient had become more than just a subject of study. He had become a symbol of the limitations of medical knowledge. Despite all the advancements in medicine, despite all the theories and tools they had at their disposal, they could not solve the mystery of his condition. They could not bridge the gap between the man who had been and the patient who now stood before them. As the months continued to pass, the patient's case remained unresolved. The doctors, although still trying to offer explanations, were slowly starting to accept that they might never fully understand what had happened to him. They had theories, of course. Some believed his condition was a result of a deep psychological defense mechanism, a last-ditch effort by his mind to shield itself from emotional pain. Others speculated that it was a neurological disorder that had somehow led to his disassociation from the human experience. But no theory could explain the full scope of his condition. His behavior seemed to defy every known diagnosis, and no amount of observation or experimentation brought them any closer to understanding what had happened to him. In the end, the patient became a legend in the annals of psychiatric history, a case that defied explanation, a mystery that could not be unraveled by the science of the time. He was a reminder that the human mind, for all its complexities, still held many secrets that even the brightest minds of the 19th century could not hope to uncover. And perhaps, in some ways, his case was a symbol of the struggle between the cold, analytical world of science and the messy, chaotic reality of human experience, a struggle that would continue to play out in the world of psychiatry for many years to come. As the months dragged on, the patient's strange condition continued to baffle the medical staff. Their initial excitement and curiosity had slowly eroded into a quiet despair, as each new observation seemed to raise more questions than it answered. No one could definitively explain why the man, once so full of life, had transformed into this detached, clinical shell of a human being. His ability to recite medical diagnoses with such precision was undeniably impressive, but it also highlighted the depth of his detachment from anything resembling a normal human experience. The more the doctors observed, the more they came to realize that they were dealing with something far beyond a simple case of mental illness. It was as though the very fabric of his identity had unraveled, leaving behind nothing but the cold, mechanical language of medicine. There were moments, however, when the patient's behavior seemed to offer fleeting glimpses of something more, something buried deep beneath the surface of his clinical language. At times, when the doctors asked him direct questions about his condition, there was a flicker of recognition, a brief moment when he seemed to understand that something was wrong, but that understanding quickly dissipated, swallowed by the same impassive demeanor that had defined his condition from the beginning. For instance, when asked about his past life, he would occasionally pause, as if attempting to access some distant memory, but the moment would pass without any emotional connection. His response would inevitably return to the same impersonal recitation of medical symptoms. Patient reports a lack of recollection of personal history, or subject shows signs of memory fragmentation, but no evidence of acute memory loss. Even more unsettling was his complete lack of engagement with the other patients in the asylum. Though the environment around him was filled with noise, screams, cries, and the constant hum of distress, the man remained as distant as ever. He did not react to the emotional turmoil of the other patients, nor did he seem to notice their suffering. He was like a ghost moving through the asylum, detached from the world around him. His disconnection from his environment was complete, and the doctors began to wonder if his mind had not only severed its ties to his own identity, but to the very human experience itself. He was living in a world of clinical facts and medical observations, but the emotional world that most people navigated every day seemed to be an alien concept to him. What was perhaps most disturbing was the way the patient seemed to have lost the ability to experience basic emotions. In a time when psychiatry was still in its infancy, emotions were considered fundamental to the understanding of the human mind. A person who had lost the ability to feel, to experience joy, fear, love, or even sorrow, was not merely suffering from a mental illness. They were suffering from something far more profound, an erosion of their humanity itself. And yet, the man seemed entirely indifferent to this loss. He did not mourn for his past life, nor did he seem to grasp the implications of his condition. The only emotion he appeared capable of was a clinical detachment, as if his mind had simply discarded the need for emotional connection in favor of a cold, logical framework for understanding the world. As the doctors began to reach the limits of their understanding, they sought out more opinions from outside the asylum. Leading neurologists and psychiatrists from across Paris were invited to observe the patient and offer their insights. Some suggested that the man might be suffering from a rare neurological disorder, one that had not yet been identified by the medical community. Others speculated that he was experiencing an extreme form of dissociation, a psychological defense mechanism that had so completely severed his ties to his emotions that he had retreated into a purely intellectual mode of existence. Still, others believed that his condition was the result of a deep and unresolved trauma, one so profound that it had caused his mind to retreat into the cold language of medicine as a means of protecting itself. Despite the influx of expert opinions, no one could agree on a single explanation for the patient's behavior. Each theory seemed to fall short of capturing the full scope of his condition. The neurological theories were appealing, as they offered the possibility of a physical cause for the patient's strange behavior. But no medical tests could pinpoint any damage to his brain. His cognitive functions appeared to be intact, and yet his ability to connect with the world on an emotional level had been utterly severed. The psychological theories, meanwhile, seemed to miss the mark as well. If the patient's behavior was the result of dissociation or defense mechanisms, why had he not shown any signs of internal conflict? Why did he not express any desire to return to his former life or reconnect with his emotions? His behavior was too systematic, too devoid of personal involvement to fit the standard diagnostic criteria for psychological disorders. The patient's case continued to draw the attention of those in the medical community, but as the months turned into years, the fascination began to fade. No answers had emerged, and the mystery of his condition remained unresolved. The man, once an object of intense curiosity, had become something of a sideshow, an unusual case that no one could solve, but that no one was willing to forget. As the years passed, the patient continued to live in the asylum, going through the motions of his days without ever showing any sign of improvement or change. His condition had become a permanent part of his existence, and the doctors, despite their best efforts, had come to accept that they would never fully understand what had happened to him. Despite the lack of progress in unraveling his mystery, the patient's story continued to haunt the medical community. His case was discussed in journals, debated in academic circles, and cited as a reminder of the limits of medical knowledge. Some physicians believed that his condition represented a failure of the human mind to cope with the complexities of emotion and identity. Others saw it as a tragic example of how a person could lose themselves completely, reduced to a mere collection of symptoms and diagnoses. There were even those who speculated that the patient's condition was a kind of mental paralysis, a state in which the mind had become so overwhelmed by the need to process and categorize its own experience that it had lost the ability to engage with the world at all. And yet, for all the theories and discussions, the patient remained a man who was not really a man at all. He was a walking set of diagnoses, a clinical specimen that could be studied but never truly understood. He had become an embodiment of the very mystery that psychiatry sought to unravel, a symbol of the human mind's complexity and its potential for both extraordinary brilliance and profound detachment. The more the doctors tried to pin him down, to categorize his behavior, the more elusive he became. It was as though his condition had slipped through the cracks of medical understanding, defying every attempt to define or explain it. In the end, the patient's life became a tragic testament to the limits of 19th century medicine. His case was never solved, his condition never fully understood. He lived out his days in the asylum, a shell of the man he had once been, speaking only in the cold, detached language of diagnosis. His humanity, once vibrant and full of potential, had been replaced by a clinical framework that reduced him to nothing more than a medical curiosity. His life had become a question that no one could answer, a puzzle that no one could solve. And yet, in his silence, in his detachment, he became a haunting reminder of the fragility of the human mind, and the mysterious depths that even the brightest minds of the era could not hope to understand. As the years passed and the patient remained locked within the confines of the asylum, a shift began to occur not only in the perception of his condition, but also in the way psychiatry itself began to evolve in response to cases like his. Initially, he had been seen as a rare anomaly, a puzzle that could be solved with the right combination of medical knowledge and psychological insight. But as time wore on and the theories continued to fall short of explaining his behavior, the doctors and the broader medical community began to face a deeper, more unsettling reality. There were no neat categories in which to place his condition. His case highlighted the limitations of the psychiatric practices of the time, a reminder that even the brightest minds could be baffled by the complexities of the human experience. The patient, once the subject of fascination and scholarly curiosity, had now become a kind of medical legend. His case was taught in medical schools as a prime example of the limits of 19th century psychiatry, a stark reminder of the field's inability to account for the intricacies of the human mind. He had become the stuff of academic discussions, his condition discussed in hushed tones among physicians, who continued to study him, but only from a distance. The doctors who had once eagerly sought to engage with him now found themselves reluctant to push too far, perhaps afraid that they might discover something even more inexplicable about his condition than they had already observed. It was around this time that a few doctors began to consider the possibility that the patient's strange detachment was not the result of a single illness or condition, but rather a confluence of factors, a multi-layered disorder that defied easy explanation. Some believed that he was not merely suffering from a psychological condition, but from a complete collapse of his self-awareness. This theory suggested that the man had somehow reached a state where the very concept of identity had ceased to exist for him. He was no longer able to connect with the notion of himself as a person, as a unique individual with a past, emotions, and relationships. Instead, he had become something far colder and more clinical, a creature of fact and observation, disconnected from the messy, emotional experience of being human. There were those who argued that his condition was the result of an early form of what would later be recognized as dissociative identity disorder or severe dissociation, where a person's mind splits into different personalities or states of consciousness. But the patient did not exhibit the typical signs of dissociation. He didn't display multiple personalities or dramatic shifts in identity. Instead, he seemed to exist as a singular entity, a person without any real attachment to himself or the world around him. It was as though the patient had somehow severed the emotional and psychological ties that normally bind a person to their sense of self. He had not gone mad in the traditional sense, nor had he suffered a breakdown in the conventional way. He had simply become something that could only be understood through the language of diagnosis. Others speculated that the patient's state might have been the result of an advanced form of what would eventually be known as autism spectrum disorder. While this theory was not widely accepted at the time, it began to gain some traction among certain members of the medical community. Some argued that the patient's extreme detachment from the world around him, his inability to process emotional or social information in a normal way, could be indicative of a form of autism that was poorly understood in the 19th century. However, this explanation did not fully account for his intellectual capacity. The patient was not intellectually impaired in any way. On the contrary, his ability to discuss medical terms and diagnoses with precision suggested a sharp, analytical mind. This sharpness, however, was not coupled with any emotional depth or empathy. The patient's case seemed to defy the more common symptoms associated with autism, leaving doctors to grapple with the question of whether there were other, more obscure disorders at play. As these theories continued to emerge and evolve, a subtle change began to occur in the way the asylum staff interacted with the patient. Where once there had been a sense of duty, a desire to understand and solve his case, there was now a growing sense of resignation. The doctors, still dedicated to their work, had come to terms with the fact that they would never be able to provide a definitive answer.